Thank you.
Thank you. So I want to pick up on an earlier comment that heterogeneity is our friend. And I think we've run from heterogeneity, seeing it as a basic failure of whatever we're doing, wanting to see that our impact was homogeneous across all of the groups. And I think what we've done is we've adopted a mindset which isn't helpful to us, which is that standardization is good. Standardization and uniformity is good in manufacturing light bulbs. And the kind of follow-on conclusion from everything should be the same leads us away from really doing the investigation of treatment, heterogeneity, response that I think can inform the next series of questions about what's working for patients and what's not. I just don't think we've spent the time doing the kinds of analysis of the people for whom things succeed and for whom they fail and why. The results we move on to the next study, but there are underlying reasons sometimes that may not be apparent at first blush. And I think both the quantitative interrogation and actually qualitative assessment can be helpful. My guess is that if you analyze all of the baseline variables, well, there are differences in outcomes of PCI and CABG patients. I think probably one of the more important things that's driving overall differences in mortality is what the patient experience during those procedures. So with PCI, people go in for a procedure, the cardiologist says, you're having a roto-rooter job, you'll be back to work tomorrow, right? Everything's gonna be fine. For the patient undergoing cardiac bypass surgery, it's a catastrophic, kind of surgery. The family's all in an uproar. And what happens after that in terms of the kinds of lifestyle changes that we know can make a difference in terms of secondary cardiac prevention? Well, my guess is there are differences because of the extent of the patient's experience with that. And you can look at what happens for people who do, in fact, adopt secondary prevention, and they do stop smoking, and they do the lifestyle activities, and they increase physical activity, they do better. And these are areas where we've done studies in CABG patients and PCI patients. And the vast majority of PCI patients do not make and sustain behavior changes at 1 year or 2 years after surgery, at which point they're back for revascularization. But I don't think we'd look at that necessarily unless we said, let's take a group of people for whom it was a success and failure and really study them and see what can we learn from talking to them about that. So I think part of investigating drivers of variability or heterogeneity in treatment response, we have to, it helps us to expand our ability and our prognostic armamentarium. I think we have to look at variables beyond those that we look at in a narrow framework, and including depression, social isolation, all of the things that we know can determine outcomes, but we can't, there's no blood test for it. Dr. Horwitz has showed a long time ago, social isolation predicts mortality 6 months after an MI. There's nothing I can do with the cholesterol that's going to predict that, right? And so we have to expand the level of predictors. The other thing I would say is that I think that we have a major opportunity for expanding our ability to collect data from patients directly, sort of crowdsourcing the interrogation of people's successes and failures. They're already sharing those experiences with each other on the internet. And I think those stories, if we can get some quantitative data from them as well as qualitative data, can help shape the direction of how we would go about really studying the treatment response heterogeneity, which in fact may be related to outcomes and may not. But I think it's a major opportunity. I think we've run away from it because we want everything that we do to work, but I think it's a major opportunity for learning more about that and for learning more about customizing how we can better tell patients the treatments that should be customized for them. So I thank you for the opportunity to share a few thoughts.
Okay, and our second commenter is Mark Cullen, who is a professor of medicine at Stanford, where he is chief of the Division of General Internal Medicine.